Welcome back, everyone. Let's continue revising strabismus. This is the second video revising strabismus. We will talk right now about strabismus evaluation. Here, the first topic in evaluation is the diagnostic positions of Giza, and this is repeated. We have mentioned this before. We mentioned that we have the primary position and 6 cardinal position in which we can isolate only one muscle which is responsible for this field of action. And also we have straight up and straight down positions. This is mentioned before. Also, we have the near fixating position, which is convergent somehow. Okay, let's go to the variants of cover test, which is cover and cover test and alternate cover test. Here, this alternate cover test, in which I cover one eye, and while I'm removing the cover, I cover the other eye. So here, the eye doesn't have any wrist, and this will confuse the brain. This will cause fusion disruption. So this is extremely important in diagnosing subtle phoria. Phoria means that you have tendency to squint. It is not it is not manifest strabismus. It is true strabismus actually, but it is not manifest. It is latent. Okay, so it is important in diagnosing latent strabismus. Also, here in this alternate cover test, I want to mention something. Yes, it is something like that. I'm covering the right eye, then the left, and then the right, and so on. I'm noticing whether the eye has any corrective movement or not. Here, the eye doesn't have any corrective movement. So here, the eye doesn't have any phoria. Okay, so these are missing slides because of the format. Look at this one. Look at every eye. Here, you can see that this eye has a corrective movement out, and also this eye has a corrective movement. After removing the cover, this eye is diverging. Okay, so this means that this eye has a tendency under the cover to deviate in. So this is called isophoria. Isophoria means that the eye has a tendency to deviate in. Okay, this is the reverse. Look at the corrective movement in each eye, which is in here. This is a corrective movement. This means that this eye has a tendency, or these eyes have tendency to deviate out under the cover. Under the cover, the eye is out. When you remove the cover, the eye has a corrective movement. As you see, this is called exophoria. It is a tendency of the eye to deviate out. This is hypophoria versus hyperforia, or hypophoria in one eye and hyperforia in the other eye, and this is logic. Here, look at this right eye, and look at this left eye. Here, this right eye has a tendency to deviate. What? Look again here. Yes, it has a tendency to deviate down because it has a corrective movement. Its corrective movement is up. So the right eye has hypophoria, and the reverse for the left eye will have hyperforia. Okay, the left eye will have hyperforia. This is called right hypophoria, or left hyperforia, or both right hypophoria and left hyperforia. Okay, the results of the cover, the results of the alternate cover test. If there is no movement under the cover, the patient has a correct muscle balance. If the covered eye deviates, heterophoria is present. However, the deviated eye will correct its position, and binocular fixation will be resumed on removing the cover. So, on removing the cover, the brain will continue its fusional versions. By the way, the phoria, which is tendency of the eye to deviate, is controlled by the brain power. The brain has the power to correct for this. Look at this one here. It is the Prism cover test. Also, the cover and cover test, it has the same idea, but we don't alternate between each eye. So it is diagnostic, or more diagnostic to tropia. Also, it may be diagnostic to phoria, but subtle or mild cases of phoria, the alternate cover test will be more accurate. This is written Franklin Kamsky, and this is evident in our practice, but it is not written like that in American Academy. So here we can fix this. We can fix effect here, which is alternate cover test is more used in cases of mild phoria, or is more effective in demonstrating mild phoria. Let's talk about the Prism cover test. Here, one eye is covered, and the other eye, we put a prism in front of the other eye. So here, these are the steps. Look at this one. Here, I'm covering this normal eye, this sound eye, and here this eye will have a corrective movement here in order to fix. Okay, Here, this patient has left iso deviation or left isotropia, left iso deviation. Here, the prism cover test is a method to measure the angle of strabismus. So we cover the sound eye. After covering the sound eye, this eye will deviate, or sorry, will be normalized here. Okay. After this step, we put a prism, which is base against deviation. Here, this eye is iso, so we put a base out prism, something like that. Okay. So again, here, look at this eye. This eye had a correction here, but after we put the prism, this eye will be deviated towards the apex of the prism like that. It will be deviated to its original side. Okay, so here it will be deviated in something like that, and this eye under the cover also will be moved with here. Okay, with this eye. So here I'm moving the left eye in, and the right eye will be moved in the same direction according to Herring law. Okay, after that we must remove the cover. Look at the eye after removing the cover. It also still have corrective movement, something like that. This means that this prism is not sufficient to correct for the angle of strabismus. So we can replace this by stronger prism. And here, this stronger prism will cause what? It will cause also further deviation to inward like that. And here, this eye also will be moved like that. Okay, look at the result here. This eye will be centralized under the cover, and this eye will return back to its original angle of strabismus. So this means that this prism has the same angle of strabismus like this eye, or like this case. Remove the cover. After you remove the cover, you won't notice any movement. When you do so, and when you notice any movement here, this means that you have neutralized the angle of strabismus. This is called alternate cover test, and this is extremely important. This is of choice in cases of measuring both Foria and Tropia. There is no movement with removing the cover, and this is the neutralization point. Actually, I do as if it is called double check. So I increase the power also. Here, I increase the power of this prism, something like that. Okay. After I increase this power, this eye will be deviated under the cover here to the outside. So I'll reverse the strabismus. And after I remove the cover, I'll notice a corrective movement in the opposite direction. This ensures that this prism is as powerful as the angle of strabismus. So I over correct the angle in order to check whether it is the neutralizing point or not. Okay, so here, look at the cover test. We can differentiate between strabismus and pseudostrabismus, because in strabismus you notice movement, corrective movement, and in pseudostrabismus you won't notice any movement, because here the optical axis is parallel to that of the optical axis of the other eye, but the problem is pseudo. It is false strabismus. Various types of strabismus here. To differentiate between what and what, to differentiate between the alternative or alternate strabismus and unilateral strabismus. Here, to differentiate between them, I'll do this one here: alternating concomitant divergent squint, or unilateral. I do what? Here, the patient is coming to me with this eye, which is the left eye normal here, and this eye is divergent, something like that. Okay, I just cover the sound eye, and this eye will have a corrective movement here in order to gain or regain the fixation. Okay, and here this eye under the cover will be diverged here. After removing the cover, when I remove this cover, this eye will return to its normal. If this eye return to its normal, and this eye return it again to its normal, which is deviating, this means that you have unilateral strabismus, which is exclusive to this right eye. Okay, look at this. It is exclusive to this right eye. This right eye before the test is diverged, and after the test it is diverged. Look at the other possibility. Here, this eye, which is the normal one, and this eye, which is the diverged one. We will cover this eye, and after covering this eye, what will happen? This eye will gain the fixation here, and this eye will be diverged under the cover. remove the cover. If you remove the cover and the status or the state became so, the left eye is diverged and the right eye is aligned, this means that this strabismus is alternating. You have alternating strabismus because it is alternating between the right eye and the left eye. Before the test, you have the right eye diverged, and after the test, you have the left eye diverged. Okay, so the brain doesn't prefer any eye to another. Okay, there is no preference. Here, look at this question. During routine examination, the cover and cover test reveals an outward fixation shift of either side. This is by the cover and cover test. The cover is placed over the contralateral eye. The alternate cover test reveals no shift as the cover test is moved back and forth. The correct description of this patient's motility status would be, here this is not logic, because if you have a problem in the cover and cover test, this will be manifest 100% by the alternate cover test. So this set of findings is not possible. And this is consistent with the Kamsky talk, which is the alternate cover test has a step forward in diagnosing phoria rather than the cover and cover test. So if you have a problem with the cover and cover test, this will be 100% manifest with the alternate cover test. So this set of finding is not possible, and this question is present in IDOC's questions. Here, look at the simultaneous Prism and cover test. This is important. Simultaneous cover and Prism. Look at this eye here. I have the right eye and the left eye, and here this is this eye has isodeviation, this left eye, and this eye is normal, something like that. Okay, you cover the sound eye at the same time you put the prism. Okay, so you don't cover the eye and to make here this eye to be fixating, and then you put the prism. No, you do this simultaneously in order to eliminate the fusion power of the brain, in order to just measure the tropia, not the phoria. Here we just measure the tropia. In cases of microtropia or in cases of monofixation syndrome, we must measure just the tropia, not the tropia plus the phoria. Okay, when used with Prism, which of the following test is most appropriate for quantification of tropia with no contribution from the phoria? It is the simultaneous Prism cover test. This is also a question from IDOCS. Here, also to quantify the angle of strabismus, we do the corneal light reflex, which is good in screening, not that good in before surgeries, but it is good in screening. We do so here. The light reflex is slightly nasal, nearly at the center, but with slightly it is nasal. Okay. Here, if it is at the pupil border, when the pupil size is 3 to 4 millimeters at most, this means that you have 15 degrees of isotropia here in this example. So if it is at the pupil border, you mean that you have 15 degrees or 30 prism diopter. If it is in the middle of, look at this, if you are in the middle of the iris, this means that you have 30 degrees or 60 prism diopter, and if it is at the limbus, this means that you have very large angle, which is 45 degrees or 100 prism diopter, and so on. To refine the result of Hershberg test, this is extremely rough to quantify and refine the results. You do Chromoski and modified Chromoski test. Actually, we do the modified Chromoski test, and in Kamsky and in other books, or in recent books, it is we don't rely on Chromoski, and we can consider that the modified Chromoski test as being Chromoski test. Okay, the older one, or the older test of Chromoski, we put the Prism base against deviation again in front of the deviating eye in order to make or until we make the reflex appears central like that. Okay, and this is equaling the angle of strabismus. And here for the modified Chromoski test, we put the Prism in front of what? In front of the normal eye or the sound eye. Here, if we put the Prism in front of the normal eye, look at this. here this eye will be forced to move, and this eye also will be forced to move. Here we put in front of the sound eye. This sound eye will be forced to move here in order to gain the reflex in its center. Okay, here this eye is moving by the power of the prism, and this eye will be moving by hearing law. So the deviating eye will gain the fixation, or the deviating eye will have the reflex central. So the difference between Chromoski and modified Chromoski is that we put the prism in Chromoski in front of the deviating eye, and in modified Chromoski we put the prism in front of the sound eye. Okay, that is for modified Chromoski test. Look at this one. You will have the sound eye deviating. This sound eye is deviating by the power of the prism. Okay, and this eye will be normalized due to the response of hearing law, because both eyes will move in the same direction. Yes, this is a modified Chromoski test, modified Chromoski method. Look at this one. Here I'm putting the prism in front of the normal eye. This normal eye, look at the other slide, will be deviated in. Look at this one, it is deviated in here towards the apex of the prism. Here this eye, this left eye, which is normally deviating, will be neutralized here. So you put the prism in front of the sound eye in order to make the reflex in the in the deviating eye. And this is valid in cases that you have here this eye, if this eye is not seeing. So you must do the modified Chromoski test. You put the prism in front of the seeing eye, in front of the normal or the sound eye. Okay, this is done in cases that you have to do the strabismus for just cosmetic appearance. Which is false regarding the angle kappa. The angle kappa is the angle between what and what, the angle between the pupillary line and the visual axis. Can be measured with a sinophore, yes. If large, it will cause pseudo isotropia. If it is large, it will cause more nasal shift, so it will cause pseudo exodeviation. No, so not pseudo isotropia. So this is the false one. The angle between the line of sight and the anatomical center of the corneal pupillary reflex, yes, this is the definition. It is usually 5 degrees, yes. So all of them are true except for number B, which is if it is large, it will cause pseudo isotropia. It will be called positive angle kappa, and this will result in pseudo exodeviation. A patient with presence with right isotropia, to estimate the deviation, the examiner chose to use the Chromoski method. To do this most reliably, he should what? Multiply the distance of the decentered light reflex from the center of the pupil in millimeters by 15 to estimate the deviation in prism diopters. No, here this is called or this is maybe expressing the Hershberg test, placing the prism over the fixing eye until the corneal light reflects from the non-fixing eye appears central. Yes, this is the most reliable one, and this is called modified Chromoski test, not Chromoski. But here, as I told you, Chromoski test or Chromoski method are being replaced by the modified one, the new one. Place prism over the non-fixing eye until the light reflexes appears central. Yes, this is called Chromoski, but this is old. So here, most reliably, you do number B, which is placing the prism over the fixing eye until the corneal reflex from the non-fixing eye appears central. You do simultaneous prism cover. No, this has no relation to the Chromoski test. The Chromoski test is essentially the Hershberg test, but with prism to quantify the deviation. Yes, prisms can be placed over one or both eyes. However, since observation of the corneal light reflex through a prism may be difficult, it is recommended to place the prism over the fixing eye. And this modified method, yes, it is the most reliable one about Chromoski. 4-year-old boy with Down syndrome presents with his mother, who complains of constant isotropia. On examination, the corneal reflex is central in the right eye, while the reflex lies midway between the pupil edge and the temporal limbus in the left eye. This is the interpretation of Hershberg test, and this will result in 30 degrees or 60 prism diopter. So the answer would be 60 prism diopter. All of the following tests of ocular alignment require fixation in the deviated eye for quantification of the angle of strabismus, except this again require fixation in the deviated eye, fixation of the deviated eye. The cover and cover test, yes, it will require fixation of the deviated eye. Here, the simultaneous prism cover test, yes, it will require fixation of the deviated eye. Here, the Chromoski test, if you do so by putting the prism in front of the sound eye, this won't require fixation by this eye. Also, the alternate cover test will require fixation of the deviated eye. So here, the answer will be the Chromoski test. The Chromoski test will be the good answer. Look at the Maddox rod. Here, the interpretation of Maddox rod is not that important in clinical sciences, but it is important in the first part in London exam, which is FRC Ophthalmic exam. So we will talk about this briefly. Here I'll illustrate this on this blackboard. Look at this one. Here I do have set of cylinders like that. These are set of cylinders which may be perpendicular or which may be vertical, maybe horizontal, and so on. Here, if they are aligned vertically, this will result in horizontal line. Okay, and here the patient is looking, or this set will be put. This set will be put in front of one eye. It will be put in front of the left eye, for example. So the patient is seeing a yellow or a white dot. The patient is seeing a white dot like that. Okay, so he will see a white dot in front of, or he will see a white dot by his right eye, and by his left eye he will see this line. Okay, he will see this line. If this patient has no element of phoria, this will be like that. You will have the line in the same plane of the dot. Okay, so if I put these cylinders, if they are oriented vertically, this will result in what? This will result in horizontal line, and this horizontal red line may be at the same plane with the dot seen by the other eye, and maybe above and maybe below. And all of these are possibilities of having strabismus. After that, you have to make the orientation of these cylinders horizontal like that. This will result in vertical, this will result in vertical line like that, okay? And this vertical line may be at the same plane of the white dot seen by the other eye, or it may be either to the right or to the left. All of these have interpretation. So let's talk about the possibilities here. About the horizontal deviation, here I don't have any deviation because the line is on the dot, or the dot is on the line. Okay, and here what is the philosophy of Maddox rod? It is dissociation between the right and the left eye. If I dissociate it between the right and the left eye, I'll get what? I'll get the brain in a holiday. So I eliminate the fusional versions of the brain in order to eliminate the phoria, or in order to make the phoria still latent. Okay, so here I am manifesting the phoria. I'm eliminating the fusional versions of the brain. Okay, by dissociating between the right eye, which is seeing, for example, a red line, and the left eye, which is seeing, for example, a white dot. Okay, so here no fusion will occur. But here, if the patient is orthophoric, there is no deviation. The patient has no manifest or latent strabismus. This will result in what? The dot will be on the line directly, or exactly on the line. If the patient has exo, look at this one. This will result in crossed diplopia. Crossed diplopia because here the left eye will see the white dot on the right, and the right eye will see the red line on the left. This will result in exodeviation because it is or this will indicate exodeviation after this test or by this test. The reverse, if I see the right will see right and the left will see left, this will result in, or this is called uncrossed diplopia or homonymous diplopia, and this indicates isodeviation or isophoria. This test is done for, this test is done principally for estimating the phoria in distance at a distance of 6 meters, something like that. After that, you make this vertical. You make these orientation, or you make the orientation of these cylinders vertical, something like that, to result in horizontal line. If you see the horizontal line, look at this one. If you see the horizontal line here, and you see the dot over the horizontal line or on the horizontal line at the same level, you mean that you don't have any vertical phoria. Okay. If you see here by the right eye, you see the red line, which is above, and the white dot, which is below. This means that you have what? Here, this eye, this right eye is hypophoric. Okay, so you have right hypodeviation, or you have left hyperdeviation. And the reverse here, if you see here, this right eye is down, is seeing this red line down, and the left eye is seeing the white dot up. This means that you have right hyperdeviation, or you have left hypodeviation. Okay. These are the steps of having this test, and these are the possibilities and the interpretation. Look at this one. If a Maddox rod is in front of the right eye, here the Maddox rod, the cylinders in front of the right eye, and the patient sees the red line above the white dot. Here, this means what? This patient sees the red line above the white dot. The red line is seen by what? The red line is seen by the right eye. So this patient has right hypophoria or left hyperforia. Look at this one. Where is the answer? It is here. It is right hypophoria. If it is written left hyperforia, also it will be correct. So this patient has either right hypophoria or left hyperforia. The Maddox wing had the same idea by dissociating between the right eye and the left eye, so no fusion occurs. And this is to quantify and test for phoria in near, not in far. So the right eye will see just this, and the left eye will see just this. Both of them must see this. This is indicating or pointing at 0, and this is pointing at 0. This is to quantify phoria, horizontal phoria, and this is for quantifying vertical phoria, and so on. About the fusional versions, here the vergences are the movement in two eyes. I told you this before. I told you that you have versions, which is conjugate eye movement, and this conjugate eye movement, which is versions. Here in the fusional versions is done in order to eliminate the phoria. As I told you, the eye may have the tendency to deviate in or out, and so on. And here I do have, I must have something which is the brain power in order to fuse. I have the fusing power of the brain. Okay. Here the eye is aligned under the normal circumstances, but here this eye is aligned not because it wants to be aligned, or they want to be aligned. These eyes are aligned by the control of the brain, and this is called the vergence power. Okay, I do have various levels, and I do have various amounts of vergences. Look at this one here. The convergence is the highest one, and after that it is the divergence, and the vertical is lowest. Okay, so here for far the convergence is 14 prism diopter, and for near it may reach 38 prism diopter. This is extremely large amount. Also the divergence is 6 and 16, and the vertical it is in far and near there is no difference. It is from 2 to 3 prism diopters. So here I have the highest power in the fusional vergence is convergence, and then divergence, and then vertical, and also torsional. I have torsional vergence. Here, what are the factors that can affect the vergence power? I have the compensatory mechanism. Here, If I have long-standing, for example, if I have long-standing case of forced nerve palsy, this forced nerve palsy will result in hyperforia, ipsilateral hyperforia. The eye will be deviated up, something like that. And this will result in diplopia. But in cases of long-standing hyperforia, here I may have the fusional versions of this eye. The vertical fusional versions of this eye will be higher than normal. It may reach 10 prism diopter, and this is extremely large. This is intolerable. If you put 10 prism diopter in front of this eye, it won't see diplopia. But if you put 10 prism diopter in front of any normal eye, it will see diplopia. So here there will be enlargement in the fusional versions, in the vertical fusional versions for cases of congenital forced nerve palsy. Change in vision. Here, if the patient is not seeing well, the fusion will be poor. If the patient is seeing good, the fusion will be better. So the fusional versions will increase after correcting. If the patient is not seeing or is not seeing by his glasses, if his vision is poor, this means that his fusional versions will be also poor. Also, the state of awareness. If the patient is fatigued at the end of the day, for example, this will result in decrease in the fusional versions, and this will make the phoria manifest. The latent strabismus may be manifest at the end of the day after fatigue or illness and so on. Also, the state of awareness, something like that of the fatigue and illness. And okay. For this interruption, we will complete here the orthoptic treatment. It is to treat cases of phoria. It is done by putting base with deviation in order to increase the amount of fusional versions. For example, in cases of exophoria, I want to increase the amount of fusional conversions, and the reverse in cases of isophoria. Optical stimulation of fusional versions. Here, I imagine that I have a patient with accommodative isotropia, for example, and this patient will need plus glasses. He is hyperopic, for example, +4. Here, if I decrease the amount of hyperopia of correction here, after a while, I do for this patient +2, not +4, just +2 diopters. What is the value of this? But this is not directly. This is after a period of time. This will induce some convergence for this patient, because this patient will accommodate in order to see, and this convergence will induce the divergence fusional or the fusional divergence power. So this will be exercising, this will be increasing the fusional divergence power. So this is important in patients. But I don't say that if you have cycloplegic refraction for a patient with accommodative isotropia of +4, you must give +4 at first. But after a while, you can decrease this +4 by 1 diopter, 2 diopters in order to accommodate, in order to induce accommodation. This accommodation will be accompanied by convergence, and this convergence will be accompanied by increased the amount of the divergence or the fusional divergence. This will be very beneficial for this patient. Okay, here how to calculate the AC per A ratio. This is not important in clinical sciences, but it has a question in Massachusetts. So here I do have two methods. One of them will take into consideration the interpupillary distance in centimeter, like the Hypophoria method, and the other method, which is the gradient method, doesn't take into consideration the pupillary distance. So here both methods will depend on measuring the angle of deviation in near and the angle of deviation in distance, and the difference between them over the diopteric power needed in the near situation. This will result in AC per A ratio. For example, if I have an angle of deviation of 15 isotropia or 15 isodeviation, or I use base out 15 prism diopter to neutralize the angle, so this means that you have 15 iso in near, and in distance you have 0 value. Here it is 0 value. So the difference between them will be what? Will be 15 minus 0, And if you suppose that the near situation is at a distance of 33 centimeters, so here you consume just 3 diopters. Okay, so the amount will be 5 to 1. But if you take into consideration the pupillary distance, which is almost 6 centimeters, this will result in 11 to 1. And this is to be mentioned. The gradient method, here it is different in eliciting the ACP ratio. Actually, in the example in Massachusetts, he doesn't differentiate between the methods of gradient and heterophoria. He just asking about this, about the pupillary distance, which is neglected in cases of gradient method. Here in gradient method, I just put a minus lens or a -1 lens in front of the patient's eyes in order to induce accommodation. This accommodation is equaling +1. So I put in front of the patient -1. So the patient will have to accommodate by +1 in order to neutralize this accommodation. Okay, this accommodation will result in what? Will result in convergence, and this convergence will be directly the AC/A ratio. Okay, so if I put if I'm telling you to look at distance and I'm putting -1, so you'll accommodate by +1, and this +1 accommodation will be accompanied by convergence. The amount of convergence will be, for example, 5 Prism letters, so your AC/A ratio is 5 to 1. This is the gradient. Okay, I have also the 3-step test, which is mentioned in neuro-ophthalmology, but we can repeat this again here. Here, the 3-step test is to isolate or to diagnose just one muscle in cases of vertical diplopia or vertical strabismus. Here, imagine that you have right hyperdeviation. Here, look at this one. The right eye and the left eye. Here, the right eye, which is here, will have hyperdeviation like that. Okay, and the left eye will be normal like that. Where is the problem? The problem is either in the inferiors of the right eye, because it is hyperdeviated, or the superiors of the left eye. So here I'm outlining the problem. The problem is here or here. So either I have a problem in the right inferior rectus, right superior oblique, or I have a problem in the left inferior oblique or the left superior rectus. This is the first step, to outline the 4 muscles. Okay. The second step is to make the patient look to the right and look to the left. Okay, if the patient is looking to the left gaze here and here in the left gaze, the diplopia is worsened. This means that the problem is in the muscle which is acting in the left direction. Here, look at this one. These are the left muscles, and these are the left muscles. Look at this. So the problem is either in the right superior oblique or in the left superior rectus. This is the second step. So I'm telling the patient to look to the right and to look to the left, and I'm outlining the position in which there is more diplopia or more vertical deviation. The third step, I'm telling the patient to be tilting to the right also and to the left. And here the patient is telling me that he is good with tilting to, sorry, is bad with tilting to the left. Here, this patient is tilting, sorry, this patient is bad with tilting to the right here. This patient is the direction of tilt. Here, look at this. It is pointing to the right one, pointing to the right side. Okay, so here you will notice that you have an arrow, and this arrow will be pointing to the right superior oblique. Let's make another example. If you have a patient with left hypertropia, for example, this patient will have left hypertropia, and this left hypertropia is increasing in left gaze, for example, and it is increasing in left tilt. So it is all left, all about left. Where is the muscle? Where is the affected muscle? This is an example. So let's illustrate here the right eye and the left eye. Here, look at the muscles which are responsible for actions. Here it is superior rectus, inferior rectus, Here it is inferior oblique, superior oblique, inferior oblique, superior oblique, superior rectus, inferior rectus. Okay. For the left eye, the patient has left hypertropia. So the problem is in the left inferiors or depressors or superior elevators here. This is the first step. The second step, the patient has worsening of condition in the left gaze. Look at the left gaze. Here to the left, I do have the superior rectus, inferior rectus of the left eye, and the inferior oblique, superior oblique. Here, these are the muscles which are working to the left direction. Okay. Also, the patient has a problem in the left tilt. So you make the tilt to the left here and here. Here, you are pointing to the inferior oblique muscle. So this patient has inferior oblique weakening. And these are the three-step test, or these are the three steps of Park-Pilchovsky test. This is an important one. And at least you will have one question in each clinical exam about this. Let's go to tests of sensory adaptation and binocular function. Here you have the red glass test. It is not mentioned in Kansky, but it is it does have questions in iDocs. It is important one. Here you will do what? You will do a red filter in front of one eye. Here I'm putting the red filter in front of the left eye. If the patient is only seeing this one, the patient here I know that the patient is squinting, the patient is deviating. Okay, so here it is in case of strabismus, you evaluate the sensory function after strabismus. So the patient is deviating, but you don't know whether the patient has suppression or not. So you put in front of one eye, in front of the left eye, for example. We will put this one. You will notice what? I'll notice that I'm seeing just the red point. Okay, in order to make the suppression away from the fovea, or make the stimulation away from the fovea which is suppressed, you do a prism, or you put a prism in front of the other eye. The prism will make you see the dot or the torch with its original line, okay, with its its original color, okay, which is yellow, for example. So you'll see a red dot and you'll see a yellow dot. Here, these are not in the same line. Here, this prism, by the way, it is vertical one in order to make them not in the same plane. Okay, this will result in what? This will result in, or this will indicate normal retinal correspondence because they are not over each other. If they are over each other, this will indicate that you have anomalous retinal correspondence, and this anomalous retinal correspondence is correcting for the diplopia for this patient. So you may have suppression in the first example. In the second example, you have suppression, but you avoided the suppressed area by putting a vertical prism to dissociate between both eyes. Here you have, as I told you, here you have anomalous retinal correspondence. They are in line with each other after putting the prism. In the absence of suppression, if this patient has no suppression, look at the possibilities here. Here, this patient has normal retinal correspondence, and here this line, or sorry, this light, which is yellow, will be to the right of the red. This will indicate what? This will indicate isodeviation or exodeviation. Here, the left is seeing left and the right is seeing right. The left eye, which is seeing red, will see left, okay, and the right eye, which is seeing yellow, will see right. So left for left and right for right. This is uncrossed diplopia, so this will indicate exodeviation. Okay, look at the reverse here. The left is seeing right and the right is seeing left, so this will indicate exodeviation. Okay, I have also possibilities here. I have other possibilities. Look at this. No. Okay, I have other possibilities here. If the patient is just seeing them over each other, this means that this patient has anomalous retinal correspondence, and this is called harmonious one. So if they are at the same location, if they are at the same location, this means that this patient has harmonious anomalous retinal correspondence. What do you mean by harmonious? Harmonious means that this anomalous retinal correspondence is sufficient to eliminate any sort of diplopia. This patient will retain good binocular single vision, although this patient has strabismus. Okay, look at this one. If this patient is seeing something like that, this is the light, and this is the red line. They are nearer than expected. If they are nearer than expected, they almost touching each other. This patient has also anomalous retinal correspondence, but this is called unharmonious ARC because it is not sufficient to eliminate diplopia. And here, in order to, I want to solve two questions here. I have here one question. Okay, this one. A 62-year-old man presents to A&E with one-day history of diplopia. On a cover test, he has a manifest right isotropia, a red glasses placed over the left. Look at this one, the red glasses placed over the left. And the patient is asked to fixate and at a distant point, light target. In the absence of suppression and with normal retinal correspondence, the patient should perceive the red light. What? Here, look at the patient from the start. He has one history of one-day history of diplopia, and he has right isodeviation. He has isodeviation, so the right will see right and the left will see left. So the red light will be to the left of the white light, because the red is put, the red filter or the red glass is put over the left eye. Look at this one. The red glass is placed over the left eye. So the red will be to the left. Okay. So the red will be to the left of the light, because here this patient has uncrossed diplopia. Again, 46 man, new onset of right isotropia, red glasses placed over the left again, and the patient is asked to fixate at the distant point. The patient reports that he only sees a red light. This means that this patient has an element of suppression. So we must put a prism. Use of a vertical prism can determine if the patient has normal retinal correspondence or not. Yes, this is the true answer, and this is written Franklin American Academy. In order to differentiate between harmonious and unharmonious ARC, if ARC from the start is present or not, we may use this test, which is red glass test, and also we can use another test, which is the synoptophore. In the synoptophore, you can correct for, or you can measure the objective angle of strabismus, and you can make the patient use the knob in order to correct for his angle of deviation in order to see clearly or see binocular single vision. This is called the subjective angle of deviation. Okay, look at this one. If you imagine that the objective angle, or if you suppose that the objective angle of the patient is 20 prism diopter, look at the first example. Here, the patient, in order to see clearly, he is adding here 10 and 10 prism diopter, so his angle of deviation will be 20 prism diopter. Okay, so the subjective angle is the same that the objective angle. So this patient has no element of ARC. This patient has normal retinal correspondence. Okay, look at the other example. If the patient is adjusting here, it's his subjective angle as being 0. This means that the patient has abnormal or anomalous retinal correspondence, which is sufficient enough to correct for the diplopia. This patient is seeing binocular single vision without adjusting anything. So it's his subjective angle is 0. His objective angle is 20. So here, the angle of anomalous retinal correspondence is equaling the full angle strabismus, or the full angle of strabismus. It is 20 prism diopter. So this patient won't have to adjust for anything. This patient has harmonious ARC. Look at this example. This patient has to adjust by 5 and 5. This means that this patient has 10 prism diopter as a subjective angle. This means that this patient has an element of anomalous written correspondence, but it is not sufficient. He has to adjust. So this patient has an unharmonious ARC. So you do have two methods of measuring or detecting whether the patient has harmonious or unharmonious ARC, which are the red glass test, and the other is the synoptophore. Which statement is false regarding the synoptophore? If the subjective is less than the objective, by the way, this is written in both CANSC and the American Academy. If the subjective angle is less than the objective angle, but not zero, there is unharmonious ARC. This is true if the subjective is less than the objective. The third example here it is the subjective is 10, the objective is 20, but it is not zero. This means that this patient has element of ARC, but it is unharmonious. It is not sufficient. It can measure horizontal, vertical, torsional misalignment. Yes, the synoptophore can do so. If the subjective angle is equal to the objective angle, there is harmonious ARC. No, this means that this patient has normal retinal correspondence. If the subjective equals the objective, it can test for stereopsis. Yes. About the Bagolini test, it is some sort of, or somehow like that of the Maddox rod, but here the orientation of the cylinders will be not vertical and horizontal, it will be oblique. So here the right eye will see this, and the left eye will see this. The right eye will see with these as the line in 40 degree. Here the adjustment of the lenses is in front of the right eye. I'll put it in this plane, which is 135. So the right eye will see this, and the left eye will see this. They will be crossing each other if this patient has normal retinal correspondence. Okay. Look at this one. If this patient is normal, he will see this. If this patient is having deviation, look at this deviation. This deviation is not crossing each other, so it is isodeviation. Look at this one. This patient has suppression in the left eye. In the right eye. He sees just the left. Okay, the right eye is missing. This patient has central suppression scotoma. This is called monofixation syndrome. This is an American Academy. Here, this is orthotropia. This patient is normal. This patient is just seeing with his left eye. He has right suppression. This patient has monofixation syndrome because the central part here and here it is larger. Here, the central part in one eye is absent. Look at this deviation. This deviation here, I don't see the cross. The cross isn't present in the middle, or isn't present at all. So this means that this patient has isotropia. If you see the crossing, or if you see this apex up, something like that, this means that the patient has crossing or cross diplopia. This patient has exodeviation or exotropia. Okay, here also like the Maddox rod, the Bagolini lenses can also assess torsion, but they assess only the manifest, not the manifest and the latent like that of the Maddox rod. A patient has isotropia. This is a question measured as 10 prism diopter for both distance and near. On Bagolini striated glasses, the patient reported seeing two intersecting diagonal lines at 90 degrees to each other, intersecting in the middle. Okay, here this patient has 10 prism diopter. Okay, for both distance and near. In Bagolini, the patient reports seeing two intersecting diagonal lines at 90 degrees to each other, intersecting in the middle. What is the appropriate interpretation of this test? This patient has harmonious abnormal retinal correspondence. This may be explaining this. He has no suppression. Right suppression is false. Has functional visual impairment. No. This patient has left suppression. This is also abnormal. This patient has normal binocular single vision. Actually, this patient may retain some binocular single vision, but the answer will be this patient will have harmonious anomalous retinal correspondence, because frankly, the objective angle of strabismus is 10 prism diopter, and actually this patient is seeing well. Okay, so this patient has ARC, which is sufficient for him. The 4 diopter base out prism test, and this is in cases, this is to diagnose cases of microtropia or monofixation syndrome. Look at this one. Here I'm putting this, it is very weak prism in order to test for the sensitivity in this central part, just in this foveal and subfoveal, or sorry, and juxtafoveal area. Look at this one. I'm putting this base out prism in front of the right eye, and can you see the eye will be deviated towards what? Towards the apex of the prism. So it will be deviated in. Both eyes will be deviated in the same direction. Here it is deviated by the prism. Here it is deviated by hearing glow. Okay, so this will result in what? This will result in shifting both eyes to the left. Both eyes will be shifted to the left. What is the next step? Here, this eye will have to correct its position in order to regain fixation again. It will have a corrective movement. This is the normal, yes, again, like that. So this is the normal response of putting a prism in front of a normal eye or sound eye. Look at this one. If you put the prism in front of another eye, or if you put the prism in front of this eye, which is the left one, okay, you will notice no movement. Here, if you notice no movement, this means that this eye is not seeing central. There is no central vision for this eye. This is called monofixation syndrome or central suppression scotoma. This will indicate central suppression scotoma. Okay, if you put the prism in front of the sound eye, this is the sound eye. Look at this one. You will notice that both eyes will move, okay, because this eye is normal. But if you wait, this eye won't have any corrective movement. So there is no movement from the start. If you put the prism in front of the eye with central suppression scotoma, and if you put the prism in front of the other eye, this eye with central suppression scotoma won't have corrective movement because actually the central part is suppressed. This is diagnostic in cases of monofixation syndrome or central suppression scotoma. And also, according to American Academy, this is the least reliable one, okay, least reliable. A child is suspected of having right monofixation syndrome, which single test would be most helpful to confirm your suspicion. Here, because it is a child, you must do the objective one, which is the only objective one is for prism diopter base out test. All of these, after image and fogging and Bagolini, they are very good, but they are not objective, they are subjective, so you cannot rely on them in a case of child. The after image test, which is somehow it is extremely tough, but we can pass by this test. It is easy, but it is dependent on understanding the difference between the diplopia and the difference between the images seen by the fovea simultaneously, or both fovea simultaneously. Okay, so here in the after image test, which is not written in Kansky, let's go for this. I'm just seeing a red, or sorry, a flash of light by one eye, which is vertical. Okay, I'm seeing this by the right fovea in a patient with strabismus from the start, and I'm seeing this by the left fovea. Okay, in cases of normal retinal correspondence, they are seen separately. So I'm seeing this at first, and after 2 seconds or 3 seconds, I'm seeing this. And I'm depending on my memory. I'm depending on my after image. Okay, the after image of the fovea of the right eye will result in this vertical. Left eye will result in this horizontal. And actually, I have a tape in the middle in order to make this area empty. Okay, this is the appearance if the patient has normal retinal correspondence. If the patient has anomalous retinal correspondence, his image of or the image of the fovea won't be the same or at the same location of that of the other fovea, because in cases of ARC, the fovea of the right eye won't be paired by the fovea of the left eye. Okay, and in cases of anomalous retinal correspondence, can you imagine? Here I have this eye. This is seen by the right eye, by the right fovea, and this is seen by the left fovea. Can you see this? This is uncrossed. The left is on the right, and the right is on the left. And this anomalous retinal correspondence is to correct for what? Here, this is the direction of ARC, not the direction of diplopia. This is to correct for this is crossed to correct for uncrossed diplopia. So this is in cases of isodeviation, not exodeviation. Here, look at this. This is the direction of ARC. It is not the direction of the diplopia. So this is the tough one to compare between the direction of diplopia and the direction of anomalous retinal correspondence. Okay. Look at the possibilities here. Here I do have the right eye is seeing to the left and the left eye seeing to the right. This is in cases of isodeviation. How isodeviation? No, here this is not the direction of the diplopia. This is just the direction of the ARC, which is corrective one for the diplopia. Here the patient has normal retinal correspondence, as you see. Here this patient has what? This patient has exodeviation, because here the right is on the right and the left is on the left. The direction of ARC is must be opposite to that of the direction of the diplopia. The worst 4-dot test, which is extremely important one. Here I do have 4 dots to be seen: 2 green, 1 red, and 1 white. We are using 2 glasses. We are using red in front of the right eye usually, and green in front of the left eye usually. Actually, this is not a condition. You may have these glasses designed like that like that present in Kansky. It is designed by a way in which the red is in front of the left and the right has the green filter. Okay, so this is not a condition, but let's assume that we have the red one in front of the right and the green in front of the left. Okay, here what is the result? This will be just seen by the red, and these will be just seen by the green. Okay, and here this white will be seen once by the red and once by the green. Okay, so in cases of normal individuals, you will see that this one is red. You will see 1 red, 2 green, and you will see one which is confused between red and green. It may be fused together in order to be seen by yellowish coloration, something like that, or according to American Academy, it may be confused. Once you can see this by red, once you can see this by green, and so on, like that of the retinal rivalry. Okay, here the possibilities. If you see just 2 dots of red, this means that you have left suppression. If you see just 3, this means that you have right suppression. If you see 4, this means that you have normal, either normal retinal correspondence or harmonious anomalous retinal correspondence, but the binocularity function is good. Seeing 5 dots, this indicates diplopia. In cases of monofixation syndrome, here in monofixation syndrome, when you are looking from distance like that of 3 meters, you will see what? When I'm looking from distance, I'll see one of both eyes will have central suppression scotoma. So the central retina will be suppressed. So I'll just either I see 2 or I see 3. Okay. If you make the distance shorter, if you make this plate shorter, or if you are moving towards this plate, you will find what? You will find that you stimulate more temporal areas of the retina. These temporal areas has no suppression, so you will see them normally. Okay, so you will get normal response at a distance of 1 meter or 2/3 of a meter, 67 centimeter. Look at the questions here. A patient takes the worst 4-dot test wearing the green lens in front of the right eye. Look at this, the green in front of the right. okay, and the red in front of the left. She reports seeing 5 lights, 2 red and 3 green. She has diplopia. She suffers from diplopia. This is easy and logical. Which statement regarding diplopia is true? Diplopia occurs when each of the 2 foveae of a single patient contains a distinct retinal image. No, this is called confusion. This is the definition of confusion, not diplopia. If a patient with a manifest strabismus doesn't complain of diplopia, then there must be suppression. No, there may be suppression and there may be anomalous retinal correspondence. As I told you in the introduction, that the sensory adaptation to strabismus is either by suppression or ARC. Okay, 9-year-old boy has a left esotropia of 7 prism diopter. His acuities are 6.6 OD and 6.9 OS. Visuoscopy in the left eye suggests eccentric fixation. Which of the following responses is least likely to occur with the Worsford dot test, green filter OD and red filter OS? This patient has some case called microtropia, and it will suggest small amount of eccentric fixation because it is not evident clinically. It is evident using the visuoscopy. Okay, so this is a small amount of eccentric fixation. Okay, this is a monofixation syndrome. He sees all the 4 lights for near fixation. Yes, this is true. For near fixation, he will stimulate temporally. His retina will be stimulated temporally, and this has no suppression. He sees 2 red lights for distance fixation with +5 diopter lens. Yes, because here +5 diopters lens will cause fogging of this eye. He sees 3 green lights for distance fixation. Yes, this is also evident because his other eye, or his left eye is suppressed, has a suppression scotoma. He sees 2 red lights for near fixation. No, near fixation here, I told you that it will stimulate the temporal areas of the retina, or more temporal areas of the retina. This will or more peripheral areas of the retina. This will result in better binocular functions. Stereo acuity testing, this is not that important, but here the normal stereo acuity is, let's focus on this. It is 60 seconds of arc. Here I do have the random dot tests, and also I have also the contour tests. The random dot tests like TNO and Presby and Lang, they are most definitive evidence of, or provide the most definitive evidence of high-grade binocular single vision. Actually, the contour stereopsis testing are used for screening, more used for screening, and also they may give some fallacies, and some monocular clues may be sufficient to pass these tests. The Titmus test, like the Titmus fly and other variants of the Titmus test, is an example of this screening, and here it is very gross. Here, if you have a large number of seconds of arc, this means that you have lower stereopsis. If you have worse stereopsis, if you have larger numbers, sorry, if you have smaller numbers, this means that you have more stereopsis. Here, I do have the random dot, I do have the TNO, I do have the random dot E, and also the Lang stereopsis. The Lang is important in that you don't have to wear glasses, dissociating glasses, and this is helpful, or maybe helpful in some children. Which is false regarding stereo acuity. This is not. This is a visual sciences question. It is not that important. Okay, present in iDocs, but it is not that important. The last one, it is the Prism adaptation test. Here it is the one to predict the binocular functions after the surgery. Here it is predictive one, to align the visual axis to help predict whether fusion may be restored with surgical or prismatic alignment, especially in adults. Here, this is the purpose of the Prism adaptation test, is to determine whether the patient has potential for strepsis? No. The ability to achieve sensory fusion, a restrictive or paretic defect, a stable deviation over time. No, here it is number B, which is the ability to achieve sensory fusion after surgery. This is for the Prism adaptation test. This is the end of this part of the revision. We'll complete the third and the final one in the next session. Thank you.